Auzubillahiminash-shaytanir-rajim. Bismillahir-rahmanir-rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. We are going to present and discuss colorectal malignancy. I am Dr. Faisal Bilal Lodhi, and I will be discussing with you the colorectal malignancy in three parts. This is the first part. We'll start with the clinical scenario. A 68 years old male presented with history of painless bleeding per rectum for last 6 months. He also complains of frequent episodes of abdominal distension. On examination, he looks pale and emaciated. Abdomen shows moderate distension and a palpable mass in the left iliac fossa. What is your differential diagnosis? What investigations will you suggest? Give your treatment plan. So if you concentrate upon the scenario, what important things come into your mind? One is that 68 years old. This patient is falls in the elderly age group, and he presents with the history of painless bleeding per rectum, and that is for the last 6 months. So there is painless bleeding per rectum for last 6 months, and there are frequent episodes of abdominal distension. He looks pale and emaciated. Abdomen shows moderate distension and a palpable mass in the left iliac fossa. So we have to consider what are the differential diagnoses and how will we investigate this case, and we have to give the treatment plan for this case, which has been highlighted in this scenario. Coming on to the incidence of colorectal malignancy in the colon, most of the colonic malignancy occurs on the left side of the colon, and among this the most commonly affected area is the rectum, left-sided colon and rectum, which is mostly involved in this malignancy, and usually the malignancy is adenocarcinomas. So the left colon is mostly involved. Anyhow, it can occur in the cecum, in the ascending colon, in the transverse colon. It can also occur in the descending colon, and the highest incidence is seen in the sigmoid and the rectum areas. The common features of clinical features of the colorectal malignancy, usually these patients they have got slow blood loss, which leads to anemia. These patients present with altered bowel habits, meaning thereby every person has got a specific bowel habit. Some people pass the stools once a day. Some people pass the stools twice a day. Some people pass the stool every second or third day. So if there is a change in the bowel habit, one has to think about that there is something wrong, and this altered bowel habit is one of the features of colorectal malignancy. Another thing is that blood or mucus in the stools. So this is another clinical feature. Another is the bleeding per rectum. Fresh bleeding per rectum is also called as hematochezia. So if there is fresh bleeding per rectum, then one should also think about that there are chances of having colonic malignancy. Abdominal distension may occur, and this abdominal distension is due to the obstructive lesion, which is causing the features of retention of the intestinal contents proximal to the lesion. Then there may be weight loss. Patient may present with intestinal obstruction. Mostly these patients present with chronic obstruction. These patients present with repeated episodes of obstruction which gets relieved on itself, and then ultimately they may present with acute intestinal obstruction. Next is the feeling of incomplete evacuation, spurious diarrhea, and tenesmus. All these three features are because of malignancy which occurs in the rectum area. The feeling of incomplete evacuation after passage of the feces, patient still feels that there is fecal matter lying in the rectum, and still the patient desires to pass the feces. Spurious diarrhea means that this is not the true diarrhea. Actually, there is hard fecal matter, and from proximal colon, thin fecal matter, it trickles down, and this is called as spurious diarrhea. Otherwise, spurious means false. So this is a false diarrhea. Normally there is no diarrhea, but the patient passes small amounts of mucus and thin fecal matter from the proximal colon when the distal colon is obstructed by the lesion. Then tenesmus. There is a strong urge to pass the stool, but nothing comes out. Patient feels that he has to pass the stool. He goes to the toilet, and no fecal matter passes. Maybe some mucus or blood comes out. So these three features, the feeling of incomplete evacuation, spurious diarrhea, and tenesmus, these strongly suggest rectal malignancy. Other physical findings include pallor, emaciation, abdominal distension, abdominal mass. This abdominal mass may be because of the fecal matter proximal to obstruction, which fills the colon and is palpable per abdomen, or it may be the malignancy itself inside the abdomen. Then in the right hypochondrium, if you find a mass, then you have to differentiate it from right colonic mass or from the liver. Liver moves with respiration, and it has got a specific feel. If the liver is enlarged because of the metastasis in the liver, then usually the surface of the liver is irregular. The examination of the patient with suspected rectal malignancy is not complete without the examination of the chest and spine. One has to examine the chest, auscultate the chest, because there are chances of metastasis in the chest, and also palpate for the spine. Sometimes there are bony mets which may have involved the spine. A very important part of examination is the rectal examination. There may be hemorrhoids present, and these hemorrhoids may be secondary to rectal malignancy. The cases we have seen that the patients have been operated for hemorrhoids, but because the surgeon did not do the digital rectal examination, so the rectal malignancy was missed and the hemorrhoids were just operated. So please be very careful. Digital rectal examination and thorough proper rectal examination is required in all cases of hemorrhoids, because these hemorrhoids may be secondary to the rectal malignancy. Digital rectal examination may reveal a rectal mass, so one has to feel for its size, its extent, and its fixity. Is it involving whole of the circumference of the rectum? Does it allow the passage of the finger, or is it completely a constricting lesion? In cases of completely constricting lesions, the patient usually presents with intestinal obstruction. Usually these growths are friable and they bleed on touch, and when you examine your finger after digital rectal examination, you may find blood on your finger. In females, pelvic examination is very important, and vaginal examination is done to rule out the involvement of vagina, and usually it is the posterior vaginal wall which is involved in cases of anterior rectal growths. So thorough rectal and pelvic examination are mandatory in these cases. Another part of examination is the proctoscopic examination, and the advantage of this is that one can directly visualize the tumor in the rectum, in the distal rectum, in the middle, and in the proximal rectum. That can be visualized, and direct biopsy can be taken under vision. So this is a very important part of examination, in which you can get the visual look at the at the mass itself, and you can have the biopsy under vision. So this is the end of our part 1 of the colorectal malignancy. Now we will proceed on to the second part of the presentation. Thank you very much.